Hi, I'm Dr. Jack West, a medical oncologist in Seattle, Washington. In early November of 2018, we got the at least brief results of the MYSTIC trial in the form of a press release. And I wanted to outline the design of this trial as well as some of the key results and what this means moving forward. So taking a step back, here is the trial design for MYSTIC. You can see it's a trial for first-line treatment of patients with advanced non-small cell who do not have an EGFR mutation or an ALK rearrangement and who have squamous or non-squamous non-small cell lung cancer. The trial as designed, as far as I can see, did not have any restriction for PD-L1 expression, though the results that have been reported focus just on the subset of patients with PD-L1 of 25% or greater, and that's based on the assay, SP263 assay that's used in the AZ trials with durvalumab. This was a large trial of over 1,100 patients who were randomized 1:1 to a standard of care arm of platinum doublet chemotherapy, just any of a few histology appropriate options, versus two investigational arms, one of durvalumab as monotherapy and the other as a combination of durvalumab with the CTLA-4 inhibitor tremelimumab. And the trial had co-primary endpoints of progression-free survival as well as overall survival. So what have we learned? We got some results, very brief, in the form of press releases that came out as early as June of 2017, and last year we learned that the trial didn't meet its primary endpoint of progression-free survival improvement in patients with PD-L1 of 25% or higher. And then in early November of 2018, so just a few weeks ago, we see that it didn't meet its primary endpoint of overall survival either in patients with this, the subgroup of patients with PD-L1 of 25% or greater. But we also got more than just a binary "it failed." We got a little bit of information on the actual results, and specifically saw that the hazard ratio for durvalumab versus chemo in overall survival was 0.76, and this was not statistically significant, but it wasn't far off. In fact, it just missed for statistical significance due to alpha spending, and I understand that if the hazard ratio had just been 0.74 instead of 0.76, it would have been statistically positive. Was not, though. And then we also learned that the hazard ratio for overall survival in the durva-tremi combination versus chemotherapy was 0.85, so not as good. We didn't hear anything more about a broader population, just the 25% and greater. Now, some of the media reports portrayed this as an abject failure, and I would say it's not quite that bleak, but it's not good news. And I think it's worth considering a little more nuance than that. So how bad is it? Now, notably, this question of chemotherapy, standard of care versus immunotherapy has been studied with pembrolizumab and was positive for pembrolizumab in the more selected population of patients in KEYNOTE-024 reported in late 2016, and this was with a threshold of 50% PD-L1 expression. That was a very positive trial, and we also learned earlier in 2018 about KEYNOTE-042, also pembro versus conventional chemo doublet, but with a less selected population of 1% or higher. And so the MYSTIC population falls in between those two groups of more selected in 024, less selected in 042. So what's telling, though, is that although we can't say that it's terrible that durvalumab didn't live up to what pembro did in 024, a more selected population, what I think is most concerning is that it didn't look as good as pembro in the 042 trial. And specifically, this study looked like it was really driven by the most favorable results that were seen for pembrolizumab in the high PD-L1 expression of greater than 50%, and the trial was still positive despite diluting with the half of the patients who fell below 50% in the 1 to 49% population. But the results were still good enough that that the dilution kept the trial positive. It was not turned negative despite that. And this is a less selected population than in MYSTIC. So in contrast, durvalumab wasn't sufficiently favorable for overall survival even in a less diluted population. So it just doesn't quite measure up in the first line setting as monotherapy. On the other hand, it didn't miss by too much, hazard ratio 0.76, so not total failure, just not nearly good enough. What I think is also interesting is that the combination really looked worse, and I'm certainly pessimistic about immunotherapy combinations based on this, at least this particular combination. How much this bleeds into our view of combinations like nivo-ipi, I think, is up for debate, but I think it's a concerning finding when the combination looks less favorable than the monotherapy. Now, I think it's also important to emphasize what these results don't mean, and by this I mean we have durvalumab as a clear standard of care in the stage 3 setting as consolidation for up to a year after patients have received chemoradiation for unresectable stage 3 non-small cell and have not had progressing disease. So this is based on the PACIFIC trial, and in that study, durvalumab was associated with a very significant improvement in progression-free survival, and we've learned recently also overall survival. And this is a difference of about 10% in overall survival at 2 years. So this is good enough to have become an FDA-approved option and is a clear standard of care right now. I would note that the MYSTIC trial, though negative, is a different study, a different population, different question, and we should not second guess our use of durvalumab in a setting in which it's been well studied in a very well conducted randomized phase 3 trial and is our FDA-approved standard of care based on the results in a different setting. Now, at the same time, I think there is some question of whether an agent like pembrolizumab might look even better in this situation, but we don't have data on that right now, and it won't be my preference to use a less tested agent in consolidation in the absence of more data. But there are several trials looking at various immunotherapy strategies being integrated into stage 3, and we'll have to see whether they come out as more positive and potentially supplant consolidation durvalumab. But today, PACIFIC is the trial, and it's what guides my standard of care, and I think should remain everyone's standard of care. In conclusion, I would say that MYSTIC doesn't lead to any changes in our current standards of care for stage 4, as well as no change in standard of care for stage 3. And I think it's particularly instructive that the combination of durva-tremi looked unfavorable, not just compared to chemo, but looked less favorable than durvalumab alone. And we'll have to see whether this is a trend that's repeated in other settings with other combinations, but I'm certainly not enthusiastic about durva-tremi. And I think these results lead to a general questioning of the older premise that I and many others had, that these agents were way more similar than different. As we see more trial results in similar settings, we're seeing differences that may not be great, but are enough to be considered clinically significant. And we may see that there's some agents and strategies that clearly bubble to the top, and that these immunotherapies are not just interchangeable from one to another. I'm interested in your thoughts on this as well as other related questions, so please leave any comments. I hope you'll like, comment, and subscribe.